as a surgeon, you become blind at some point.
Surgeons think that because they're a surgeon, that they know everything.
There's always space for learning all the time.
Very important to try to analyze the steps of the surgery.
May I ask you how you felt with our case today, Dr. Ragak?
Well, it was a really nice case. I got to learn very important tips that not only add to the efficiency of the operation, but again save a lot of time. And I know that it's very critical in this kind of surgery, the time factor. The shorter, as we were previously discussing, the shorter the time, the less incidence of infection. So.
Have you done the penile implant by yourself before?
Yes, many times.
How many cases?
I could do around 6 to 7, maybe 10 cases a month back in Egypt.
Just yourself?
Yeah, all by myself.
Where did you get the training before? All of that before?
Well, I'm originally a lecturer of urology in the university, Ben Suef University in Egypt. I got my training at Cairo University, my master's degree in urology, then my doctor's degree in urology in Cairo University. Then I went for a fellowship in the U.S. at the Cleveland Clinic for 2 years. Followed by 1 year at Houston, Texas.
Mm-hmm. So you have a long history of the training with the prosthetics.
Yeah.
In the head of this. Mm-hmm. May I ask you why you chose to come over here to get trained by Dr. Osmanov?
First of all, Dr. Osmanov is one of the best in Europe when I researched, and there's always space for learning all the time. You want to get the, especially from the experts in this field, because you want your service, you want to always advance in your service. And I was fortunate enough to win the ESSM award, the sponsorship for this fellowship. It's a 3-month fellowship, and they gave me 5 choices across Europe, 5 centers of excellence, and here at the UKSH was one of my top priorities, and I was lucky to win it. Dr. Osmanov.
So you were able to see today, Dr. Osmanov and I myself have some years of experience with the penile implants, but obviously we have a master today, right? Dr. Wilson was with us. How did you feel? Those two, his sons are scolded by his father, their father.
We were just talking about that. I wish to be a third son from Egypt because, I'm thrilled. It's only been a week now and then a busy week full of interesting cases. And to top that, this summit with, I know Professor Wilson's the godfather of the whole implant world. So, I'm on top of the world right now.
Well, not only that, but today we did the penile implant, which is a 45 years it's been around, and we did it through an incision that has only been described 15 years ago for putting an inflatable in. I think Egidio in Brazil was the first guy to publish it in about 2004, but it didn't really catch fire until Dr. Park learned how to do it and opened his clinic in Seoul, and then has since done 600 through the subchronal incision. So by far and away the most of anybody in the world through that incision. And today, what did you feel made it an attractive incision for you to use in Egypt?
Actually, I think I would adopt this incision as soon as I'm back in Egypt, because there are a lot of advantages. Number one is that you completely avoid the hematoma, because I know whatever approach through the scrotum, because of the nature of the tissues there, you get this large swelling and hematoma. You have to use the mummy wrap. The problem with the hematoma, it increases the rate of infection, number one. Number two, you delay the time to cycle, or when the patient is able to use the pump. The other thing is that when you use the subchronal incision through the original circumcision incision, then cosmetically it's not there anymore. So it's a beautiful incision.
So all through your trainings and the many other things, what do you think the most important in terms of to prevent the post-operative infection or post-operative complication? Let's say, what's the most important thing you have to do during your surgery?
I think it starts maybe before surgery. It's the proper preparation of the patient, proper selection of the patient. If you have any septic foci, you have to take care of that. And then it has to do with the operative theater, the setting, your instruments. And then it has to do with the operator himself, his skill, his expertise, the technique he uses, the approach, the time of the operation. I think all of this affects the time of operation from the beginning to the end. As soon as you open your incision and the closure, even the closure, maybe the antibiotics used during the procedure, the way you handle the device itself, the implant itself. Afterwards, I know Dr. Wilson might not approve that, is the postoperative antibiotics, but we were just discussing that they have no that much of a role afterwards. It's the peri-operative antibiotics. I think, yeah, that's the most important thing.
Yes, I highly value your efforting of the continued education because, like you saw today, Dr. Osmanov and I become used to our own ways of doing things. Like we so become familiar with it. We cannot recognize any faults or any downsides of what we do. As a surgeon, you become blind at some point, right? So training like this,
Correct.
Someone should tell you that you are doing something wrong. So that's what you can learn, or I can learn throughout the surgery. I think that was the most important thing today. You saw. That's what I believe. Because there will be a day that you become experienced surgeon. And you know that you are a good surgeon, but that's the time when you need a master surgeon to correct you.
And I think, like I said, there's always areas of improvement. I mean, they would never stop to improve your procedure, your technique.
It's such a joy to have all the surgeons doing the surgery together and while sharing their ideas and thoughts. They have all logics, but their logics is not always right. So
Yeah, I mean, surgeons think that because they're a surgeon that they know everything, and so they add things to the procedure that have never been proven to work and never been proven to decrease infection. But when someone who has more experience watches that surgeon, they say, this guy is wasting a lot of time. He's changing his gloves, he's putting more sutures in than he needs to, many things. For example, on a scrotal incision, if you sew the incision, if it's a vertical incision like this, and you start at the top and you put in stitch, 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 you waste time. The correct way to do it is to put one stitch in the middle, and then put a stitch halfway and a stitch halfway, and that's generally the whole closure. But if you start at the top and go like this, you put in more stitches. So you always have to be thinking of saving time, and because not only is time money, because you're spending the time in the OR, but the patient is paying for additional OR time, plus the amount of time that the incision is open is so important for decreasing infection. I'd like to ask Dr. Osmanov, who's never had a fellow before, have you?
No.
So how does it feel after 1 week to have this Boston Scientific Fellow?
So I'm very proud to have Dr. Rajab in our team, because he's hungry to know, and he always asks me, and observing tricks during the surgery.
Is this the first year of the fellowship?
This is the first year.
First year, okay.
And of course we are lucky to have such a great fellow with us. And I wish a lot of success in his career, and of course be sure that all of us will support you in your clinical life, and you can always contact me or Professor Park or Professor Wilson if you have any question. And they're mostly important, but I think what I learned, and I always learn something, having Dr. Wilson or Dr. Park in the hospital for the experienced surgeon, and I always ask me, well, I saw the surgery today, and what are the most three things I've learned? It's very important to trying to analyze the steps of the surgery, and I learned it from you, Father. And, it's very important. I always do it with my fellows or residents.
Yeah. I think that's always, when you're a teacher, you always step back and say, what's the most important thing you learned today? But you only get 2 or 3 sentences to answer the question.
Mm-hmm. I have a question for you, Father.
Yeah.
Not all students are as smart as Dr. Rajab. You know, many students of yours are like us. We're very stupid. We're very, hard to teach, very stubborn and those stuff. How were you able to manage all those teachings?
Yeah, it's a funny deal. Some guys, they have it immediately. Others take many visits. I mean, for example, there are several American surgeons who probably took 6 sessions with me to get them to the point where they could do it in less than an hour.
Oh.
So it's a matter of training, and what I find, Sean, today is that it's even more difficult with young doctors because of the laparoscopic and the robotic emphasis in their training. Many of them don't do very much open surgery. These guys, they finish their training and they're a wizard at the robot, but in terms of making an incision and tying knots and getting exposure, they don't really know what to do. And so it's even harder now, and that's why fellowship training like Ahmed is taking is going to really pay off, because we're going to have fewer guys do these tricky, risky little operations in prosthetic urology.